In this important module on basics of vaginal delivery, I am going to talk at length first about terminology used in fetopelvic relationships. First, I will discuss the different terminologies used to describe fetopelvic relationships. Without understanding these basic terms, one cannot understand and describe mechanism of normal labor. The terms I will be describing and showing pictures of in the next few slides are lie, attitude, presentation, presenting part, denominator, position, engagement, and station of fetal head. Lie is defined as relationship of the long axis of the fetus to that of the mother. The lie of the fetus can be longitudinal, oblique, or transverse. In 99.5% of cases, the lie of the fetus at term is longitudinal. The relationship of fetal parts to one another is called as the attitude of the fetus. Fetus has following attitude as regards relationship of the fetal head to the trunk. The head can be flexed, deflexed, partially extended, or completely extended. Presentation is that pole of the fetus which enters the pelvis first. The different presentations are cephalic presentation, breech presentation, or shoulder or acromion presentation. Presenting part is that part of the presentation which lies lowermost in the pelvic cavity and is felt on per-vaginal examination. For example, in cephalic presentation, depending on attitude of the head, the different presenting parts can be vertex, brow, or face. In breech presentation, the different presenting parts can be buttocks in frank breech presentation, both feet, genital organs, and buttocks in complete breech presentation, or they can be single or double footling or single or double kneeling in the rare incomplete types of breech presentation. In shoulder presentation, the presenting part can be shoulder, chest, back, or rarely a hand in hand prolapse. Denominator is the arbitrarily chosen point on the presenting part which is referred to the various quadrants of the pelvis in order to describe the position of the presenting part. For example, in vertex presentation, the denominator is occiput, in face presentation it is mentum, and in brow presentation it is nasion, and in breech presentation it is sacrum. Position describes the relationship of the fetal presenting part to the maternal pelvis. It is the situation of the denominator with reference to the four quadrants of the maternal pelvis. Position is always described in relationship to the right or left side of the maternal pelvis. The different positions in vertex presentation are left occipito-anterior or V1 position, right occipito-anterior or V2 position, right occipito-posterior or V3 position, and left occipito-posterior or V4 position. Of course, there can be left or right occipito-transverse position as well as bang occipito-anterior or bang occipito-posterior positions. Determination of the position is crucial to forceps application and traction. Fontanelles and sutures are used to determine the position of the fetal head. The various positions in vertex presentation are left occipito-anterior or V1, right occipito-anterior or V2, right occipito-posterior or V3, and left occipito-posterior or V4 as shown in these pictures. Determination of the position is crucial in forceps application and traction. Fontanelles and sutures are used to determine the position. When the largest transverse diameter of the fetal head, that is the biparietal diameter in vertex presentation, crosses the pelvic brim, the head is said to be engaged. This generally is achieved when the leading boning point of the skull has reached the level of the ischial spines, that is, the station is 0. In primigravida, the head engages at 37 to 38 weeks of gestation, whereas in multipara, it occurs at full term or late in labor, maybe in first or second stage. The diameter of fetal head that comes in contact with the pelvic brim when biparietal diameter enters the pelvic brim, that is when the head engages, is called as the diameter of engagement. The diameter of engagement varies with the attitude of head. In vertex anterior position, the diameter of engagement is suboccipitobregmatic. It measures 9.5 cm. In occipito-posterior position, the diameter of engagement is occipitofrontal and measures 11 cm. In face presentation, the diameter of engagement is submentobregmatic and measures 9.5 cm. And in brow presentation, the diameter of engagement is mentovertical and measures 13.5 cm, which is the largest diameter of engagement in cephalic presentation. The position of the leading boning point of the fetal head in relationship to the ischial spines is called as station. When it is at the level of the ischial spines, it is referred to as station 0. If it lies above the spines, it is minus, that is -1, -2, -3, -4 or -5 for each centimeter it is above the ischial spines. And if it is below the ischial spines, it is plus, that is +1, +2, +3, +4 or +5 for each centimeter it is below the ischial spines. In modern obstetrics, the station of the fetal head is determined by abdominal palpation using the rule of fifths instead of by vaginal examination. Now I will demonstrate how to determine the station of the fetal head by abdominal palpation. For this, place the fingers of the right hand transversely on the fetal head and measure the number of fingers from the pubic bone to the base of the baby's head. A head that is floating will be mobile and fit 5 fingers above the pubic symphysis. As the head descends, the portion of the head remaining above the brim will fit fewer fingers as seen here. This diagram, taken from my book Practical Obstetrics and Gynecology, illustrates the various stations of the head by abdominal palpation as I have just showed in the video. These maneuvers are not always truly diagnostic and may require ultrasound examination to confirm the findings. Nowadays, intrapartum transperineal ultrasound examination is used to document fetal descent and rotation in second stage and to assess the presence and extent of caput. One technique is to measure the angle between the symphysis pubis and the leading part of the fetal skull, called as the angle of progression by transperineal ultrasound examination in the second stage. Station can be determined from angle of progression using a formula and tables which are available for the same. Another way is to measure the head to perineum distance serially with transperineal ultrasound. As descent of head occurs, the head to perineal distance will decrease. Now I will explain the concept of synclitism of the fetal head. Normally, when the head engages, the two parietal bones are at the same level. This is called synclitism. When one parietal bone lies below the other due to lateral inclination of the fetal head, the sagittal suture lies nearer to the promontory or symphysis pubis. This is called asynclitism, and there are two types: anterior asynclitism and posterior asynclitism as shown in the pictures. When the posterior parietal bone is at a lower level than the anterior parietal bone, it is called anterior asynclitism. Here, the sagittal suture is nearer the pubic symphysis. The converse is true for posterior asynclitism. Its obstetric significance is as follows. Asynclitism brings the shorter super-subparietal diameter, which is 9 cm, to enter the pelvis instead of the biparietal diameter, which is 9.5 cm. Remember, slight degree of asynclitism may occur in normal labor. Anterior parietal bone presentation is more favorable than posterior parietal bone presentation because 1. During correction of asynclitism, the head meets only the resistance of the sacral promontory, while in posterior parietal bone presentation, the head meets the resistance of the whole length of the symphysis pubis. Secondly, the head lies more in the pelvic axis with anterior parietal bone presentation. And lastly, with posterior parietal bone presentation, lower uterine segment is more liable to stretching and rupture. Asynclitism is sometimes referred to as ear presentation. Posterior asynclitism is also known as Leadsman's obliquity, and anterior asynclitism is also known as Naegeli's obliquity.